All right, let's get straight into it. You're prepping for Step 2 CK, so we're skipping the basic physiology fluff today and dropping right into the diagnostic funnel you absolutely need for renal acid-based questions. We're going to break down exactly how test writers build those incredibly tempting wrong answers, and more importantly, how you can sidestep them. Starting off with the fundamental algorithm, your very first move on any of these questions is to check the arterial pH. Under 7.35, that's acidemia. Over 7.45, alkalemia. Once you've locked that in, you compare the PaCO2 against the bicarbonate to figure out if you're dealing with a respiratory or a metabolic branch. It sounds simple, right? But the exam isn't just going to ask you to name the disorder. They are going to make you work it up. Okay, Section 1, high anion gap acidosis. When the funnel points you toward metabolic acidosis, your immediate next step is calculating that anion gap. Here's the crucial split. If the gap is over 12, it's high. That literally means unmeasured acidic compounds are building up in the patient's blood. But if the gap is normal, say between 8 and 12, it simply means the patient lost bicarbonate. And to keep electrical charges balanced, their chloride levels went up to compensate, which, by the way, is exactly why it's also called hyperchloremic metabolic acidosis. Now, for that high anion gap workup, examiners aren't just going to ask you to recite a mnemonic. They want to test the clinical clues. If the vignette gives you a patient with hypoperfusion, like sepsis or cardiogenic shock, look for an elevated lactate. If they've got renal failure, you're looking for an elevated BUN pointing to uremia. Hyperglycemia? That's your cue for the ketones of DKA. And if you calculate an osmolal gap, where the measured osmolality is way higher than what you calculated, you need to seriously consider toxic alcohols like methanol or ethylene glycol. Moving right along to Section 2. Acidosis exam traps. Let's see how the examiners use this physiology to set traps. Picture this vignette. A patient gets wheeled into the ED after a generalized tonic-clonic seizure. Their labs show a clear anion gap metabolic acidosis driven by high lactic acid. Your first instinct as a med student is probably to treat that abnormal lab value, right? Well, don't fall for it. This is a classic exam trap. What you're seeing is transient post-ictal lactic acidosis from severe muscle exertion. It almost always resolves completely on its own within about 90 minutes once the seizure stops. So your correct answer here is to just observe. Don't go pushing meds to fix a number. But that brings us to the obvious question. When do you actually reach for sodium bicarbonate? Generally speaking, you really want to reserve it strictly for severe, acute metabolic acidosis where the pH drops below 7.1. And why isn't it automatic for everyone else? Because giving bicarb carries some real risks. It can actually cause myocardial depression and even increase lactic acid production. The benefits just do not outweigh those risks unless that pH is critically low. Here's another massive trap. The deceptively normal pH. Examiners absolutely love using a near-normal pH to hide deadly mixed primary acid-based disorders. Say you have a patient with DKA who is also throwing up violently. The metabolic acidosis from the DKA basically cancels out the metabolic alkalosis from the vomiting. The same exact thing happens with an over-diuresed heart failure patient who has underlying COPD or someone with salicylic toxicity. A pH of 7.4 does not mean your patient is fine. You have to check the bicarb and CO2 to uncover what's really going on. All right, Section 3, normal gap and RTA. So jumping back to the other branch of metabolic acidosis, let's decode the normal anion gap. The absolute top differentials you need to instantly recall here are severe diarrhea, excessive saline infusion, Addison's disease, and renal tubular acidosis, or RTA. RTA is a hugely high-yield topic for Step 2, so let's look at how they'll frame it. Vignette clues are everything here. If they give you an elderly patient with poorly controlled diabetes, hyperkalemia, and mild renal insufficiency, lock in type 4 RTA. But if the vignette describes an infant failing to thrive with a normal anion gap acidosis, you should be thinking type 1 or 2. And if they hand you an elevated urine pH over 5.5, or mention a urease-positive bug like Proteus mirabilis, that is a blazing neon sign for type 1 RTA. Nailing the exact type is critical because the treatments are wildly different. Type 1 and type 2 RTAs require alkali therapy, like sodium or potassium citrate. Type 4 RTA, though, is basically an issue of aldosterone resistance or hyporeninemic hypoaldosteronism, usually from damage to the juxtaglomerular apparatus. So for type 4, you're reaching for furosemide or mineralocorticoid replacement to handle that high potassium. Okay, Section 4, metabolic alkalosis and diuretics. Pivoting over to the other side of the algorithm, metabolic alkalosis. This is where your pH is over 7.45 and bicarb is up. The absolute key to unlocking these questions, it's looking directly at the urine chloride. The urine chloride is basically the sorting hat that tells you if your patient is saline responsive or saline resistant. Here's how it breaks down. A low urine chloride, meaning under 20, tells you the kidneys are desperately trying to hold on to volume. It's saline responsive. You'll see this with vomiting, nasogastric suction, or general volume depletion. And you treat it by giving normal saline. On the flip side, a high urine chloride over 20 means it's a saline-resistant hypervolemic state. Think excess mineralocorticoid activity like primary hyperaldosteronism, Cushing syndrome, or severe hypokalemia. Pumping them full of saline won't help here. You have to fix the underlying cause. But wait, there is a diuretic trap you have to watch out for. Long-term diuretic overuse leaves a patient volume depleted, which logically should mean a low urine chloride. But if the patient literally just took a loop or thiazide diuretic a few hours ago, that drug is actively blocking sodium and chloride reabsorption. So temporarily, the urine chloride looks artificially high. Then, when the med wears off, it plummets back to low, creating this weird waxing and waning effect. So read the timeline in the vignette super carefully. Let's wrap this up with Section 5, Rapid Review Questions. We've covered a lot, so let's pressure test this algorithm. I'll give you 3 classic Step 2 presentations. Rapid Review 1. A patient overdoses and comes into the ED with a fever, ringing in their ears, vertigo, and they're breathing fast. You check the ABG and the pH is suspiciously near normal. Take a second to think about what drug causes a mixed metabolic acidosis and respiratory alkalosis. You got it, it's salicylate, or aspirin toxicity. The fast breathing triggers an early respiratory alkalosis, which is quickly followed by an anion gap metabolic acidosis. Those two competing forces pull the pH toward the middle, creating that deceptively normal lab value that you have to recognize quickly. All right, rapid review 2. Let's apply those vignette clues from earlier. You have an elderly patient with poorly controlled diabetes. They present with a non-anionic gap metabolic acidosis, hyperkalemia, and mild renal insufficiency. What is it? It's type 4 RTA. That diabetes damages the juxtaglomerular apparatus, which leads to hyporeninemic hypoaldosteronism, and that perfectly explains both the acidosis and the high potassium. Last one, rapid review 3. A patient has metabolic alkalosis and hypokalemia secondary to severe recurrent vomiting. Think about whether this vomiting causes a saline responsive or saline resistant state. Will their urine chloride be high or low? It's going to be low, less than 20. Vomiting puts the patient in a hypovolemic, saline-responsive state. The kidney is going to overdrive trying to hold on to everything, so chloride virtually disappears from the urine. You treat this with normal saline. So the next time you see a quote-unquote normal pH on an exam, just remember, it might be hiding a massive mixed acid-base war underneath. Master this diagnostic funnel, dodge these classic traps, and you're going to crush Step 2. Keep at it.